Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome back to The Deep Dive, where we take a mountain of information, compress it, and hand you the crucial nuggets you need to know. Today, we are deep diving into a toxicological emergency that is often misdiagnosed and terrifyingly fast. Serotonin syndrome.
Serotonin syndrome, or SS, you'll sometimes hear it called serotonin toxicity, is a really critical, potentially life-threatening adverse drug reaction. For anyone managing a patient's medication list, a robust and, frankly, quick understanding of this is it's non-negotiable for safety.
And what's the fundamental cause? I mean, what makes this syndrome so different from other drug reactions?
It really, it boils down to a massive exaggerated party of serotonin.
A party, I like that. So just way too much of it.
Way too much. We're talking about a flood of serotonergic activity hitting, well, everywhere. Both the central nervous system.
The brain and spinal cords.
Exactly. And the peripheral nervous system, too. The whole body.
And that overstimulation creates that famous, dangerous constellation of signs. Mental status changes, neuromuscular excitability, and autonomic instability. But here's the detail that I think really matters for anyone looking at a patient's chart. The trigger isn't usually what you'd expect.
That's absolutely right. While, sure, it can happen if someone takes a massive overdose of a single medication.
Right.
The most frequent way this syndrome actually kicks off is through a drug interaction.
Oh, okay.
So we're seeing combinations of different agents, sometimes at totally normal therapeutic doses, that just happen to affect serotonin through multiple different pathways.
So if you're looking at a complex medication history, that vigilance has to extend well beyond just the prescription psychotropics, right? We're talking over-the-counter stuff.
Peripheral supplements.
And this is the one that gets me, even certain antibiotics.
Exactly. So our mission today is really to master the signs of SS, especially that specific clinical triad. And most importantly, understand the mechanisms that connect some really surprising culprits to this dangerous outcome. This is all about knowing the critical life-saving management steps.
Okay, so before we get into that long list of culprits, let's quickly review the normal serotonin highway. What's supposed to happen?
Well, serotonin, or 5-HT, it's a core neurotransmitter. It all starts with the amino acid L-tryptophan. That's the building block.
Right.
Once it's made, it gets packaged up and stored in these little pouches, vesicles, by something called a vesicular monoamine transporter, or VMAT2.
And when a neuron fires, that serotonin is released into the synapse where it does its job signaling the next neuron?
Correct. Now, the body is highly regulated. After serotonin does its job, you have to control it. And that regulation happens in, three main ways. The enzyme monoamine oxidase A, or MAOA, breaks some of it down. Some of it provides feedback to stop more release. And most famously, the serotonin reuptake transporter SERT pulls it back into the first neuron to be recycled.
So when we talk about drugs messing things up, we're generally talking about agents that are disrupting one or more of those control points, which lets too much serotonin just hang out in the synapse.
Precisely. And that excess stimulation hits receptors all over the body. The clinical effects of serotonin syndrome are almost all driven by the overactivation of two specific receptor types, 5-HT1A and 5-HT2A.
The 5-HT1A receptors, those are linked to the milder symptoms, right? Like anxiety, restlessness, maybe some of those little muscle jerks, myoclonus.
That's true, but the 5-HT2A receptors, they are the key players in the severe picture of serotonin syndrome. They're strongly implicated in the dangerous stuff extreme hyperthermia, uncontrolled hypertension, and those really serious cognitive changes.
And that's actually the basis for some of our specific treatments later on, targeting that 2A receptor.
It is. Antagonism of 5-HT2A is central to the pharmacology of our antidote.
Okay, let's unpack this. Serotonin syndrome is most commonly triggered by combinations of drugs. So what are those 5 core pharmacological mechanisms we need to have memorized?
The list is really diverse, which is exactly why it's so tricky. We kind of organize them by how they overwhelm the system.
Makes sense.
First, and maybe the most dangerous in terms of just how bad the reaction can be, is inhibition of metabolism.
Okay.
This happens when we block that enzyme, MAOA, which stops serotonin from being broken down. The classic monoamine oxidase inhibitors, the MAOIs like phenelzine, are notorious here.
But the danger isn't just limited to the classic psych meds, is it? This is where those surprising culprits come in.
Absolutely. We have to be aware of the antibiotic line solid. It's used a lot for resistant infections, and it has potent MAO inhibitory effects. Methylene blue, a dye used in some surgeries, and to treat methemoglobinemia is another powerful MAO inhibitor. And then you have the herbal category.
Yeah.
St. John's wort can also inhibit MAO. Combine that with something else, and you've got a problem.
So that's inhibition of metabolism. The second mechanism is probably the most common one, just in terms of patient numbers, I'd imagine. Inhibition of reuptake, blocking SERT.
This is the big bucket with all the household names. SSRIs like fluoxetine or sertraline, SNRIs, TCAs. But the list is much, much bigger than just antidepressants. This is the real danger zone for combination therapy.
And here's where it gets surprising. You mentioned opioids and cough syrup.
Yeah, that's a huge clinical blind spot. Several high-risk opioids are actually reuptake inhibitors. The big ones are tramadol and meperidine.
Right.
And maybe the most sort of insidious risk involves a common over-the-counter agent, dextromethorphan. It's in so many cough suppressants.
What does it do?
It acts as a SERT blocker and an NMDA receptor antagonist, which really ups the risk profile.
Yeah.
Combining an SSRI with a simple cough medicine is like a classic recipe for a mild to moderate SS event.
That makes medication reconciliation incredibly complex. You're hunting for hidden serotonergic mechanisms in drugs that aren't even for mood disorders. What's number 3? The increased release agents.
These are the agents that just force the neuron to dump all its serotonin stores. This includes your classic stimulants like amphetamines, illicit drugs like MDMA, cathinones.
Cocaine?
Cocaine, right.
Yeah.
And I see you've got lithium on this list, too.
Yes, which is important because lithium is often used to augment antidepressant therapy. It's thought to increase 5-HT release while also making those postsynaptic 5-HT1A receptors more sensitive.
Good point. Mechanisms 4 and 5.
Fourth, we have direct receptor agonism. The most common example here would be the triptans, right? The migraine meds.
Exactly. They directly stimulate 5-HT receptors. And fifth, just increasing the building blocks. Increase serotonin synthesis. This is with precursors like L-tryptophan. It's especially dangerous if you pair it with an MAOI because you're flooding the system with raw material and then stopping the breakdown.
That covers the what and how of the drugs, but you mentioned susceptibility. It's not just the drug, it's the patient.
Exactly. You have to consider how the body processes these agents. A huge risk factor is CYP450 inhibition. These are non-serotonergic drugs that block the metabolic enzymes in the liver. The cytochrome P450s, specifically CYP2C19, 2D6, and 3A4, which are supposed to be breaking down the serotonergic drug.
So you could have 2 drugs that are fine on their own, but when you put them together, drug A blocks the disposal system for drug B, and drug B just accumulates to dangerous levels.
That is the perfect way to visualize it. Fluvoxamine, for instance, is famous for inhibiting CYP1A2 and 2C19. Can cause the levels of other serotonergic drugs to just skyrocket, turning a therapeutic dose into an accidental overdose almost instantly.
And the patient's own DNA plays a role too.
Absolutely. Genetic polymorphisms are becoming more and more recognized. If a patient is a slow metabolizer because of their CYP enzymes, they naturally accumulate the drug and can hit toxic levels much more easily. And on top of that, variations in the receptor itself, like the T102C polymorphism in the 5-HT2A receptor gene, can change how sensitive a patient's receptors are. Some people are just predisposed to a severe reaction, even at standard doses. And of course, age and organ function are critical. Elderly patients and those with poor renal function just clear drugs more slowly.
All that complexity leads us to the moment of diagnosis. How does this massive serotonin surge manifest? This is where prompt recognition saves a life. The symptoms appear fast. 60% of patients show signs within 6 hours. We need to focus on the 3 core components of the clinical triad. Let's start with number 1, mental status changes.
These are broad, really reflecting a global CNS overstimulation. We see everything from anxiety, restlessness, and agitation. Sometimes it looks just like a panic attack, all the way up to delirium and confusion.
And in severe cases.
In the most severe cases, the patient can become obtunded, have a seizure, or even slip into a coma.
Okay, component 2. Autonomic instability. Tachycardia, high blood pressure, dilated pupils, all common. But the hallmark sign, the one that commands immediate attention, is hyperthermia.
This is probably the most critical insight from our sources. We are not talking about a simple fever. The temperature often goes over 40 degrees C, and it can climb past 41.1 degrees C in severe SS.
And here's the crucial aha moment that changes treatment. Why the temperature is so high.
Precisely. This extreme heat isn't caused by the brain's thermostat being broken. It's because of muscle hyperexcitability and sustained uncontrolled contractions, that clonus and rigidity we're about to talk about. Think of it like a massive engine revving constantly, generating a ton of heat.
So if the hyperthermia is coming from the muscles, that changes everything about how we treat it.
It means that antipyretics, like acetaminophen or ibuprofen, are totally ineffective and contraindicated. If you give the patient Tylenol, you're not even touching the source of the problem, which is the muscle activity. You're just risking liver injury while their core temp keeps climbing. It's like fighting a fire caused by a short circuit by pouring water on the wires. It's just the wrong tool.
That's a great analogy. Okay, finally, the third component, neuromuscular abnormalities.
Right.
This is the physical evidence of that engine over-revving.
Right. We see hyperreflexia, which tends to be worse in the lower extremities, myoclonus, and a generalized tremor. But the key distinguishing feature, the absolute key, is clonus.
Those involuntary rhythmic muscle contractions.
Yes. Whether it's inducible, spontaneous, or even in the eyes, clonus is the sign that the Hunter criteria really center on. And in severe SS, that hyperactivity progresses to a profound, dangerous muscular rigidity.
And that rigidity in clonus is the difference between mild SS, which might look like the flu with some twitching, and severe SS, where the patient is rigid, super hyperthermic, and facing immediate risks of rhabdomyolysis and kidney failure.
It's so vital to recognize that serotonin syndrome is a purely clinical diagnosis. There is no blood test that says, yes, this is it. We run labs only to exclude other things or to assess the damage, like checking a CPK for muscle breakdown.
So if there's no test, we have to rely on the exam and the history. Which diagnostic tool helps guide the clinical eye?
We really rely on structured criteria, specifically the Hunter serotonin toxicity criteria. They are highly sensitive, 84%, and incredibly specific, 97%. And they place the finding of clonus right at the center of the diagnosis.
Misdiagnosis is so common because SS looks like a lot of other things. We absolutely have to know how to separate it from its most dangerous mimic, neuroleptic malignant syndrome, or NMS.
This distinction can be life-saving. Think of SS as a sprint and NMS as a marathon. SS has a rapid onset minutes to hours, and it's all about hyperactivity.
Okay.
The patient is hyperkinetic, they have tremors, hyperreflexia, clonus, and crucially, because of that hypersympathetic state, they're usually sweaty or moist, and their bowels are hyperactive.
NMS, on the other hand, is much slower and looks totally different.
Much slower. Days, even weeks to develop, usually after starting an antipsychotic. NMS is characterized by a lack of movement, bradykinesia, and that classic lead pipe rigidity. And critically, their reflexes are normal, no hyperreflexia, no clonus, and the patient is often dry.
We also have to differentiate it from anticholinergic toxidrome, right? Which involves confusion, but the skin and mucous membranes are classically dry and flushed, not sweaty like in SS.
And finally, malignant hyperthermia. That's a rare genetic disorder from certain anesthetics. You can rule that out because those patients typically have hyperreflexia and clonus is absent. That's why recognizing the specific type of muscle hyperactivity is so critical.
Okay, now we move to management. If we suspect SS, the core principle, the one non-negotiable step, is what?
Immediate discontinuation of all suspected serotonergic agents.
That's step one.
Always step one. Most mild cases will start to resolve within, say, 12 to 24 hours just with that and some supportive care. But you have to factor in the pharmacokinetics.
Like with fluoxetine.
Exactly. Fluoxetine and its active metabolite have these notoriously long half-lives. We're talking 1 or 2 weeks. That can significantly prolong the symptoms and require a much longer observation.
Once we stop the drugs, what is the first-line pharmacologic intervention?
That is emphatically benzodiazepines. They are the initial, first-line treatment for agitation, tremor, any neuromuscular hyperactivity, even in mild to moderate cases.
So their benefit is way more than just sedation.
Completely. Sedation is helpful, sure, but their primary benefit is inducing muscle relaxation. By controlling the rigidity, the clonus, the tremor, you are controlling the engine that is generating all that heat.
Right.
By reducing that muscle activity, benzos indirectly lower the core body temp and mitigate the risks of rhabdomyolysis and severe lactic acidosis. And if the patient has a seizure, they're obviously superior.
If that aggressive use of benzodiazepines isn't enough for a moderate case, if the patient is still agitated and hyperthermic, we then move to the targeted serotonin antagonist, cyproheptadine.
Right. Cyproheptadine is a non-selective antagonist of the 5-HT1A and 5-HT2A receptors, so it directly counteracts the root cause. It's reserved for moderate SS that is refractory to good doses of benzos. The typical initial oral loading dose is 12 milligrams.
But the research on this drug has some major limitations, correct?
It does. It has success in case reports, animal studies, but critically, there are no randomized controlled trials in humans that support a survival benefit. It is absolutely not a substitute for aggressive supportive measures.
And it's only available orally.
Which is a huge problem. It's very difficult, if not impossible, to give to a severely agitated, confused, or intubated patient.
For those patients who might need continuous sedation but maybe not intubation, we mentioned another option.
Yes, for moderate cases refractory to benzos, or where you're really worried about respiratory depression, we can turn to dexmedetomidine. It's an alpha-2 agonist that modulates serotonin release and reduces sympathetic output.
The big advantage being less respiratory suppression.
Exactly. But the drawback is that it lacks anti-epileptic activity, so you have to keep that in mind.
And if the patient is in a true severe crisis, temps over 41.1 degrees C, and they're not responding to any of this.
This is a dire emergency. If that agitation or rigidity is uncontrollable, you have to move to immediate or tracheal intubation and neuromuscular paralysis. You are literally just stopping the muscle activity that is generating that life-threatening heat.
And when you paralyze the patient, the choice of agent is key.
Absolutely. You have to avoid succinylcholine because of the theoretical risk of hyperkalemia with all that muscle damage. Non-depolarizing agents like rocuronium or vecuronium are the preferred choice.
One last thought on management: avoiding agents that make it worse.
We need to be wary of those high-risk opioids again, like fentanyl or oxycodone, if you're using them for pain. They can actually exacerbate SS. Hydromorphone is generally considered a safer alternative.
And you'd also avoid haloperidol and propranolol.
Right, they lack robust evidence or could even make things worse. And of course, aggressive external cooling is often necessary alongside everything else.
This deep dive has given us a really concise map of serotonin syndrome. It's a toxicological emergency driven by complex drug mechanisms, not always a massive overdose. And its recognition hinges on that clinical triad, especially clonus, hyperreflexia, and that severe hyperthermia.
And the treatment is anchored by rapid recognition, stopping all the agents, and aggressive supportive care focused on stopping the muscle activity, which means benzodiazepines are your first-line pharmacologic treatment to manage the root cause of that hyperthermia.
The best defense, for you, the clinician, is still prevention. A comprehensive medication history, including those surprising culprits like tramadol and cough syrup, and a deep awareness of how CYP450 interactions can turn a therapeutic dose into a toxic one.
Indeed. Now, consider this final thought. Given the increasing worldwide use of antidepressants and the rapid expansion of pharmacogenomic testing, we are developing the ability to predict risk at a molecular level. If specific genetic variations in key metabolic enzymes or even receptor structure, like we discussed with that 5-HTR2A gene, can predispose a patient to a catastrophic serotonin syndrome, what's the immediate ethical and clinical implication? Should pharmacogenomic testing become a mandatory part of risk assessment before starting or combining any serotonergic therapy in the next, say, 3 to 5 years? That's something for you to mull over.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.